If you can see, sir, my screen is
Yes, yes,
visible.
slides are visible. Just please make it full screen. Yes. Thank you.
Yes. Yeah, now it's visible, sir. So I'll
Yes,
start
yes, you
now.
can
I'm
hide
Dr.
that. You can hide this, the
Suvir
stop
Dev.
sharing, and near that
Hello.
there is height
I did
to hide it. Yes.
my
Yes.
MBBS
Thank you.
from UCM. Did my MBBS and in post graduation from Delhi University. I followed it up with the Fellowship of Cataract Refractive Comprehensive Anterior Segment from Vinu Eye Institute, Delhi. Then I joined as senior resident Lady Harding Medical College, and currently I'm doing FNB Vitreous Retina and UVA. I'm a trainee over there of National Board of Examinations at Sir Gangaram Hospital. I recently cleared FRCS Glasgow, FRCS Edinburgh, and I would like to share my experience. I also cleared FICO in 2020 and 21. So first, I would like to give a brief introduction for this examination. I appeared for this examination in New Delhi. That was the Part 3 examination. First thing, if you hear about this examination, a very popular notion. It's very easy to pass this examination and equally easy to fail this examination. You will understand as I go through my slides why this notion is so popular about this examination. Very importantly, this examination does not test how many facts and figures you can remember in ophthalmology. Instead, it actually tests your ability to apply that knowledge in an apt clinical scenario, to deduce some differentials and form some provisional diagnosis, and then how to steer through the management of the patient. That is very important. This degree gives you a job in the United Kingdom at NHS, and basically, it's okay if someone doesn't want to relocate from their parent country, that is fine. But if someone really wants to relocate to UK, they make sure that they need safe doctors. That is very important. The word is safe doctors. Okay, so safe doctors, this is their way of examining you. You may be knowing macular hole to the back of your hand. If you do not know the hierarchy of management, you're gone. I've seen many people who were actually retina fellows, passed out fellows practicing retina. They failed the retina station. That's surprising. But this is the irony, and this is the surprise behind this examination. This is what this examination actually tells: easy to pass and easy to fail. A very important, strong word of caution, which I would like to give all of you. Do not appear for this examination if you have not seen the patients and examined them thoroughly, all by yourself, not just once, but several times. Every time faster and even faster. Very important that you know uh, just by watching YouTube videos won't do the job. There are several videos on the social media platform where you see examining the pupillary reactions, examining the proptosis, ptosis. They look very good, lucrative. You may watch them 4 or 5 times, 6 times, whatever. But later on, when there is an examination scenario, you know, things turn differently. You have an examiner, you have no one, you cannot rewind the video and see where you missed. Okay, so that is basically you are using your brain to do this. You need to actually bring this all to your spinal level. That is the key to success in this examination. You have to bring everything to the spinal level. The examination you have to bring to the spinal level. What are the resources? Obviously, the temple, the temple university, I would say, MVUPGO, the classes, the videos, the experiences, they all helped me a lot. Very importantly, Kansky's Clinical Ophthalmology 9th edition. Why did I write must? It is very important. Why? It is written by authors who work and practice in United Kingdom. The management plan of the patient is structured accordingly, and what examiners expect from you is chronologically written, be it clinical features, be it investigations, be it management, from mild to moderate to severe. If you see all the whatever is written in whatever is written in Kansky, every word of it is very important. can see is important. Past candidate experience is extremely important in your final days. I will discuss later why final days. Dr. Chua's website for experiences and videos, Dr. Chua's book on clinical examination techniques. This is very important. This actually tells you how to do it. Now, this is only tells how to do it. You have to do it on your own. The YouTube video of Dr. Gada's channel for clinical examination, I use this for pupillary reactions, assessment, and the proptosis examination. FRCS Ophthalmology Cakewalk book by Dr. Mamta Mittal. This is an excellent book. Mind it. Dr. Mamta has done a great job in compiling everything she could. Whatever theory is given in this book, every line, every word is important. Clinical examination techniques are also given. Oh hell, you see emergency medicine clinical scenarios also given. You see ophthalmic clinical scenarios also given. Me and my friends, I had a group of friends. We used to discuss the clinical scenarios. They say 60-year-old woman, sudden DOV. What are the differential symptoms and everything? And we go on like that. Try to speak in front of the mirror so that you gain confidence. If you feel that you lack confidence in speaking in front of the mirror, Oxford Handbook of an Emergency Medicine. Another important element. Emergency medicine, way back we left. We are ophthalmologists, right? So it was very, very difficult to adapt to the emergency medicine. But the good thing about this book is that there is a of clinical scenarios, the common clinical scenarios they ask usually my condolences.
Dr. Suvir, hello. Dr. Suvir, hello. Hello. Dr. Suvir, hello. Dr. Shreyas,
Yes, sir.
acha, you can hear me, no?
Yeah, I can hear you.
Acha. I thought
Yes.
my connection is poor or something.
No, everything is
So
right.
that
I think we are not able to hear Dr. Suvir actually.
I think his connection is poor or something.
Yeah, some problem, I think.
So okay, I'll
We'll,
call him.
uh,
Do you have his number?
yeah, I have, sir.
Please call him.
Okay.
Hmm.
Hello, Kaushik sir.
Ah,
Dr.
Dr.
Shreyas
Suvir.
here. Sir, he's not picking the phone. I tried both his mobiles, both numbers what I have.
So
Because I have to log out from Zoom.
it's
Now I logged
it's
out from Zoom
okay.
and tried again.
एक बार we'll wait for like around 10 minutes. Then I'll tell it is better to do it in a day when he's free and the internet connections are okay and at least 10 people are there because actually iOS is going on, no?
Yeah, that's everything
So
is there. Yes.
people might be there or something.
Yeah. I'll just message him on both his numbers, whatever I have. I'll message him.
Just do it and we'll wait for around 5 minutes and then I think we can close if
Sure,
he's
sure.
not there.
Okay, sir.
So that we can do it in a more optimum time when more people can join because
Yes.
this will be definitely helpful to others.
Yes, sir. Yes.
Sir, am I not audible, sir?
Yes, Dr. Shubir, you are audible. Actually, connection was I think your voice got muffled and we could not see your screen. So,
Sir, now is
Dr.
it
Shubir,
visible?
I had a request. So, can we do it in some other day? Because the attendance is also not very good. So,
Yes, sir, not a problem, sir. I can do
like,
it tomorrow.
yes. So, tomorrow, which time, what time?
So tomorrow I can do it 8 p.m. IST.
Okay. So,
I think some people are working in the morning on Sunday as well, so I can do it at 8 p.m. also.
okay.
Not a problem.
So,
I think 8 p.m. everybody would be back home.
yes, I think. I'll make the settings so that anyone can join. I'll be on flight that time. So, or we can do it now also if you want.
Yeah, whatever you
I am
wish.
ready,
Yes,
sir.
no. Yes. Other Dr. Farzana, Dr. Farhana are there. Do you want it today? So we can do it, close it today only. Hello?
Yeah, we can do it today also, Kaushik. I
Yes,
mean, whatever is
let's.
comfortable for you and
No, no,
Suvir
no,
sir.
no, no, no. I am okay. I think better because we have started. Let's do it today only. Close kar dete hain.
It's okay. Yes, sir. Whatever.
Yes, and exams are very near actually. 21st is the
Yeah,
exam.
it's very near. I mean, we don't know what to revise also.
Yes. It's better. Let's get it done today only. Please, Dr. Shubir, share your slides.
Okay, sir. Now can you see?
Not yet.
Wait. Is it visible now, sir?
It has started sharing, not shared yet. Yes, now it's
Uh,
visible. Please make it full
I
screen.
shared, sir, actually, can see. Yeah, it's full
Dr. Shubir, your voice gets
screen, sir.
muffled. It's not clear actually. The connection might be poor or something. You are not audible.
So do let me know when to start. If you can see the full screen, it's already full screen from my side.
No, you have to make it make
So
go
now
to
my
the
voice is
slideshow
audible.
mode.
Moment, sir. I'll just check out my. Hello, sir. Can you hear me, sir? Now is it
Yes,
audible?
yes. Yes, yes, you are more better. The volume is better. So
Yes,
please
sir.
make the presentation full screen.
Yes, sir. Now is it full screen? Is it visible, sir?
Yes, it's visible and your voice is very clear now.
Thank you, sir.
Thank you.
So, examiner asked me to enlist all the investigations. I enlisted all the investigations, and then he asked me how to manage this case. And he told me specifically, just tell me the ocular management. Then I told him about visual acuity assessment, intraocular pressure assessment. It may be low or high. Then color vision contrast sensitivity, if possible. Corneal examination. I could see some healed keratitis or something. If I'm suspecting keratouveitis, in this case, you have to keep everything in mind. And I would like to grade the cells and flare. I would like to look at the lens for complicated cataract. And I forgot to say gonioscopy for the angles as well. And I would like to see the posterior segment evaluation for vitreous, optic disc for cupping, macula for CME or ERM. I also told him about the topical early schedule of topical steroids and then followed by tapering, cycloplegic mydriatic drug, and systemic anti-inflammatory analgesics, tear substitute for comfort. Then he asked me that if the IOP is raised, what will you do? He may be a steroid responder. Now see this. This is a very like dodging kind of a question. So he said IOP is raised, what will you do? And he may be a steroid responder. I said I would continue to use steroids and give IOP lowering medications as it is important to control the inflammation first. Sorry. And then he asked, but if you are giving steroids to the patient and if he's a steroid responder, then you're giving glaucoma to the patient. I said my aim is to bring the disease under remission as soon as possible. Steroid induced IOP elevation usually returns to normal within 1 month of stoppage of steroids. And if by chance he develops OAG later on, I'll treat for that, but I won't stop treating with steroids. This is very important. And this is a very common question which usually the examiners have asked previously as well. And he asked me that okay, if you're starting with some, he asked me about what kind of steroid you would use. I said prednisolone acetate 1% or dexamethasone 0.1%. He said what about low potency steroids? I told him that the response would be suboptimal and I will unnecessarily prolong the illness, although he had no expression after this answer. Then this anterior segment case 2 was there. The 30-year-old accidentally splashed acid while cleaning the toilet, and the examiner said, describe the findings. And I went on with cloudy cornea, limbal ischemia. The conjunctiva and limbus was totally white at that time, and total corneal clouding was there at that photograph. This is just a photograph for representation. So he said, what is the severity? And I said, as per Roper Hall grading, it is grade 4. And as I told, don't go by the image. And he said, how would you manage the case? What will be your first step in management? So first step, my friend who was with me in the examination, he said I will be giving topical steroids and topical antibiotics. The first step in the management is to copiously irrigate the eye with 2 units of ringer lactate or normal saline. All right. The examiner now stopped me here and said there is no ringer lactate. I said I'd use the tap water, and he didn't show any expressions at that time. And he said what you would do next. And I said, after irrigation, I'll examine the visual acuity, intraocular pressure via NCT. I cannot touch the cornea, it's too friable. I may injure the cornea. And details of anterior chamber if visible, and grade the extent of damage. The examiner then asked, what you do something else before this? I was confused. And the patient, and he was trying to hint me towards this. Patient is tearing profusely. He was trying to draw my attention to the tear film. He was trying to draw my attention to the puncta. I said, stain the cornea with fluorescein. Examiner, even before that, that's a part of your examination, right? The patient is tearing. Okay. I said, I'll perform syringing. The examiner was convinced. Yes, because a lot of the bolus of the chemical may seep into the canaliculi through puncta, and that actually becomes a reservoir, slowly and gradually regurgitating that chemical again and again onto the ocular surface and causing continuous damage. Then he asked me about what all treatment is to be given. I enlisted all the topical antibiotics, steroids, topical vitamin C, copious early tear substitute, sweeping of the furnaces with glass rod soaked in glycerine. And he said, would you do anything to prevent perforation? I said, BCL application, systemic anticollagenases, and topical anticollagenases. And then he asked, the cornea has scarred with total opacity and vascularization. How will you rehabilitate? I said, penetrating keratoplasty. He said, do you think it will work? And I paused for a moment and said, keratoprosthesis. At this juncture, I don't know, but I wanted to say that it depends on the severity and clock hours of vascularization of the cornea, and then I would decide whether I need to go and what structures are preserved at least, because if it has gone deeper into the anterior chamber and damaged everything, it is liable to fail, and the primary procedure. Still, if at all I have to give it a try for keratoplasty, I would like to see and grade the vascularization and examine in detail so that I can come up to a conclusion. But still, he wanted to hear keratoprosthesis, as previously told in every video of MVUPGO and other candidates, that they have certain keywords. They want to listen to those keywords. Until and unless you speak that, they would continue. But yes, they do help you out by pinpointing some your attention towards that, and they would just want to see whether you can catch that or not. The third case of anterior segment was to identify this image. And he said this is a small child and he has a corneal opacity. So he asked me the differential diagnosis. I gave that stumped differential diagnosis. Okay. Mucopolysaccharidosis, glaucoma, and the Peters anomaly and everything, the endothelial dystrophy, everything. So, and he said, what if this is congenital glaucoma and what's your management? I gave all the details of examination, including examination under anesthesia, what all is to be done, consult to anesthesia has to be sent. I would also start the child on topical drops and systemic medications. Examiner said what to avoid. Very common question. Brimonidine crosses the blood-brain barrier and may cause respiratory depression. The examiner asked that is medication a definitive treatment? Actually, it is the definitive treatment is surgery, as you all know, and medication is only in the interim period to buy time for surgery. The bell rang, and this station was over. A break of around 5 minutes is given before you toggle onto the other station. At that point of time, you don't need to talk to the candidates around, and you just need to just focus for the other one because they don't give time, and the helpers, the examination helpers, are always roaming around there, and if you talk in between or something, they object. So the posterior segment begins. This was the case. Okay, everybody can see this for photograph. This is a case of central retinal vein occlusion. The quality of the photograph which I was shown in the examination was really bad. Okay, that the splash tomato ketchup appearance was there, but most of them fumbled making a diagnosis of CRVO. So be very careful about that. But read the clinical scenario as well. 60-year-old male, sudden onset DOV. Some of the candidates answered it as ocular ischemic syndrome. Okay, and AION combined with ocular ischemic syndrome. That can also give a picture like this. But see, the ocular ischemic syndrome will never have an acute onset visual loss. Read the clinical scenario also. The ocular ischemic syndrome will have insidious onset of visual loss. 60-year-old male, sudden DOV, and hypertension. These are the keywords. Came after 20 days. This is also important. Examiner said describe. The picture was very bad, as I told, and I described the disc size, shape, vessels, cotton wool spots, frame-shaped hemorrhages in all four quadrants. And the examiner asked me to give the provisional diagnosis. This time, again, no differential diagnosis. I said this is right eye central retinal vein occlusion. He said, how will you manage? I started off with visual acuity assessment, color vision, contrast sensitivity. Obviously, if it's the case of in ischemic CRVO, these two examinations are not possible. But yes, there are non-ischemic CRVO, and the one of the entities like the venous stasis retinopathy, where you can actually measure these two color vision and contrast sensitivity and see there is an ischemic component or not. So also anterior segment for pupils to look for RAPD. I would look at the iris for neovascularization of the iris. I would perform gonioscopy to look for neovascularization at the angle, and then finally the posterior segment evaluation. Examiner said, if the vision is hand movements, now would you like to change your provisional diagnosis? Again, this is very important. He just gave me one parameter, hand movements, and the visual acuity is less than 660. Remember that Singh and Hyre classification. So the visual acuity has been reduced to below 6 by 60, but this actually does not, this points toward ischemic CRVO, but there are other parameters. So I answered this only. So I would like to examine the patient to look for RAPD, perform ERG, as well to fully label it as ischemic CRVO. Right now, just with visual acuity of hand movements, it points towards CRVO pending other tests.
Dr. Shubir, my like there should be like if even ischemic CRBO doesn't have finger or a hand movement close to face. So if the vision has reduced to hand movement close to face, then you have to rule out concomitant CRAO also,
CRVO also,
or
yes,
or ischemic optic neuropathy, arteritic or non-arteritic type. So
yes,
basically, you have to tell that also. So मतलब, if the vision is so poor as to hand movement or perception of light only in a fundus finding which shows like CRVO, you have to rule out usually there is a concomitant CRAO. And another other additional things which should be ruled out are ischemic optic neuropathy, which can be arteritic or non-arteritic. It is very rare, but yes,
hmm,
vision. So, like even in ischemic CRVO, we do not expect the vision to go down to hand movement or
yes,
PR, projection of rays to be inaccurate in such case.
yes.
Yes.
So examiner then asked me other investigations. I said fundus fluorescein angiography and OCT. And examiner OCT said that OCT you find macular edema. How will you treat? I told about intravitreal injections. He asked me the modes of giving intravitreal injections, all modes, the PNR and the monthly injections, and how many injections can be given. Uh, I said there is no count of an injection, though he did not give me any expression on that. But then he said that the FFA done shows greater than 10 their diopters of capillary non-perfusion areas. Will you treat with laser? I said no. I'll keep the patient on very close follow-up and perform panretinal photocoagulation once NVI or NVA has developed. He said, why not immediately on FFA? I said that there is no role of early PRP and results are same as done later. Why would I reduce the visual field of the patient in a haste to reduce the incidence of NVI or NVA when the results of both PRP done later, PRP done early are similar? Examiner said that you did a great job by doing PRP and the patient develops NVG and is on maximum medical medications. What next? I said I'll plan for trabeculectomy with mitomycin C. Examiner said, why not shunt surgery primarily? I said, trap with augmentation can be done first. If it fails, I can do shunt surgery later. But examiner said, when you know it'll fail, why not shunt first? I paused for a moment, and yeah, it is actually the exam scenario and everything. This moment you describe it as a stunned moment. Okay, now you're just but still. I went on. I said I can go with shunt first, but after explaining to the patient the pros and cons of both surgeries, examiner had no expression for this, and the bell rang. The station the first case was over. The second examiner took over and showed me this photograph. So, 40-year-old male complains of slowly progressive difficulty with night vision. He asked me to describe the image. I described optic disc, the waxy disc pallor, the arterial attenuation, and spicule-like pigmentary disturbance. As you can see, that was a case of retinitis pigmentosa. He asked me the differential diagnosis. I came up with retinitis pigmentosa first, and he said, "What all things can also cause such a picture?" I said, "Status post panretinal photocoagulation. You'll see the laser marks as well. You may see some NVEs. A patient may have history of diabetes. Syphilis, the great masquerader. It can also cause pigmentary disturbance like changes in the retina. But those pigmentary disturbances won't be in a ring form or won't be paravascular as retinitis pigmentosa. It may be diffuse and infections, some inherited dystrophies, and also the syndromic RPs." He asked me, how will you investigate the patient? I said, visual acuity assessment, best corrected visual acuity, color vision, contrast sensitivity, the visual field 30-2. I would look for ring scotoma, and I would also look for, I would like to also perform ERG to see diminished rod response early, and later cones are also affected. I would also like to perform OCT macula to look for CME, ERM, quantify them. Anterior segment to look for cataract. Central PSC is usually associated with the retinitis pigmentosa. I would also like to take a family history. Other family members examination and screening is also important. I would like to call upon the other family members. If at all I found similar findings in the other family members, I would like to also give a referral for genetic evaluation and systemic evaluation in cases of syndromic RP with appropriate consults to various departments. Finally, the examiner came up with how will you manage. So I said prescribe. I will prescribe glasses, surgery for cataract, look for post-operative UVI test. There's a lot of blood aqueous barrier breakdown in cases of RP, and topical and systemic CAIs, carbonic anhydrase inhibitors for CME, visual rehabilitation, referral to low vision aid center. And what type of low vision aids, he asked. I said magnifying glasses, loops. I was about to discuss about bionic eye. By that time, the bell rang. Then he gave me the second case. That was the 55-year-old male complaining of sudden onset of diminution of vision in the left eye. And the examiner asked me to describe this image. I described everything. Subtotal retinal detachment. You can see HST over here, horseshoe tear, the break at 1:30 o'clock with macula off. And examiner asked me what should be your approach. I again came up with the common visual acuity, color contrast assessment of the eye for any signs of trauma. Very important, because in trauma, he asked me why. I said that trauma may be associated with the retinal dialysis, so I will have in mind that I have to look for, if at all this I'm suspecting a retinal case of retinal detachment. I may actually have to look for retinal tears or retinal dialysis as well. And also pupillary examination for RAPD, anterior segment for cells flare, if there is associated trauma, lens status, if there is zonular dialysis, if at all associated with trauma, cataract or pseudophakic. This has important connotation with surgery, and the total retina evaluation, delineating the retinal detachment and looking for breaks with 360 degrees scleral indentation. He straight away came up, the examiner straight away came up to Linkoff rule. I described all of them, and then came the oops moment when I described everything. He took up a pen and a paper and said, Draw the diagram on this paper for the link off rules. Oh, I had to draw every link off rule, and uh, he had just a normal paper, not the Amsler Dubois chart. So it's okay. And he asked me, how will you manage the patient? I said, I would like to discuss the patient, the condition he's suffering from, and would make him understand retinal detachment. What is it? And what are the expectations for surgery? And he smiled a little and he said, what kind of surgery will you opt for? I said, scleral buckling. He said, why not PPV? And the after this, the other question would be, what are the indications of PPV and scleral buckling? And I answered correctly all the indication, and he seems to look convinced. Basically, he wanted to know. I said there is media clarity in this case. I would like to preserve the natural lens of the patient, and this is a peripheral tear. Only one tear can be seen after screening. Even I can go for scleral buckling, that is less invasive as compared to pars plana vitrectomy, which would actually entail filling up the globe with silicone oil, removal of vitreous, and later development of cataract as well. Case 3, he just showed me an image. Okay, that was the image of, and he asked me to identify the image. I identified it as the retinochoroidal coloboma. And he said, okay, how will you evaluate? I said the anterior segment examination. I would look for associated iris coloboma, lens coloboma, cataract, and evaluation of retina to look for breaks or holes, and refer to internal medicine specialist. That came up spontaneously. I was just trying to revise this coloboma just a few moments back. Luckily, I got this case. So, for the charge syndrome, as you can recall, cardiology and nephrology consult, and referral for genetic evaluation. Examiner said, how will you treat if there is no break? So, I told him that we would barrage around the collabometers area, and by that time the bell rang. So my retina station was over, and I now came to ocular motility, neuro-ophthalmology, strabismus, and emergency medicine OSCE. The first photograph was a 55-year-old male who suffered from sudden onset diplopia. He asked me to describe the image. So it was actually a right-sided sixth nerve palsy. So dextroversion, abduction deficit, and overaction of the medial rectus, and leber version was normal. And he asked me the differential diagnosis. So first, I told him that this may be a case of right sixth nerve palsy. And what else can you think? Okay, I told him raised ICP, intracranial pressure, that is the false localizing sign. An examiner smiled. He wanted to hear this keyword from me. Okay, and then examiner asked me about primary deviation versus secondary deviation. So obviously you all must have read about this, and in the MVUPGO lectures also this has been very well covered, that what is primary and what is secondary. And I answered all the points in details, although he wanted to go up to the third nerve palsy and its subsequent sequelae, which is a little difficult as compared to the sixth nerve paresis. So a difficult pertinent to the examined scenario. Okay, you have to be very careful with whatever you speak. And then he asked, how will you manage? I told him about the visual acuity, best corrected visual acuity, color vision, contrast sensitivity, refraction, and fundus to rule out papilledema. Very important. I just a few months back I talked about the raised intracranial pressure. I need to look for swelling of the optic disc. If at all it is present, I would have like to have a neurology consult also. And if at all it is not present, I would like to still have a neurology referral for focal neurological signs. And on the cursory, examiner said that what investigations you would like to get done for this patient. You would like to do MRI. So on the cursory, I won't. But yes, if there is a suspicion of raised ICT, I would like to rule out an intracranial space occupying lesion. And then he said, anything else? I said, refractive prescription, glasses, prisms, patch the eye. He said, will you go for surgery? I said, not acutely, but will consider when any further improvement of angle of deviation has ceased to occur, mostly by 6 months, and the bell rang. Then came the emergency medicine, and the examiner was a practicing physician in the United Kingdom. He immediately showed a photograph of an ECG. Although we all our colleagues, luckily I had my three friends appearing for this examination. We just prayed to God that just ECG should not, because they don't ask ECG. They don't show ECG to every candidate. Although I was not confident, but yeah, I could describe the ECG. So that ECG was of an acute myocardial infarction. Although he looked at me and said that, okay, doctor, I won't go any further. You can tell me the differential diagnosis, if and how will you manage the patient if the patient collapses, and differential diagnosis of chest pain, acute onset chest pain. So I gave all the differentials of chest pain I had read before. And I what the emergency medicine specialists, what I have heard from my colleagues and my seniors, that the emergency medicine specialist always wants to hear the protocol of United Kingdom followed. So the he deliberately added the statement, how will you manage if the patient collapses? Now, when a patient has collapsed, I would have to resort to securing the airway breathing circulation, ABC, call for help or shout for help. ECG, if available, and it's at the patient's side. Blood sugar, blood pressure, past history if the relatives are surrounding him, and dial 911 for defibrillator and ask them for to bring defibrillator. This is very important. So rest I gave the explanation of management of myocardial infarction. This was the first case, and then he showed me the other case. That was that was a face of a person. This was acromegaly. Gave answers but no expressions from the examiner. I was not able to frame sentences properly for this acromegaly, and I was fumbling with some management. Then examiner said, "Okay, no problem. You give me the detailed management of diabetic ketoacidosis." And I detailed out the explanation of DKA. I had read it well. So this completes my OSCE station. We went out. We started at around 1 o'clock in the afternoon, and I feel that uh, there is no scope of meeting the candidates who have appeared in the morning session, although you can actually meet them if at all you get a chance, that to outside the examination center, not inside obviously. And this has an important bearing. They observe all your actions in the exam center. And remember that the photographs which are shown in the morning session need not necessarily be the photographs which will be shown to you on the day of examination or on the in the afternoon session. Not at all. This is not the scenario, believe me.
Suvir, can I ask one question?
Yes.
Dr. Suvir, which of those you considered as a fatal mistakes in Viva? Any fatal mistakes that we should avoid? Ki bhai, you should not say like this, you should not start like this. Something you can guide.
Yes, sir. So what I felt that I was stressed out, quite frankly. And whenever the clinical photograph came in front of me, I was just very desperate to jump on the diagnosis which I could see. Thankfully, the examiner, sorry, asked me the differential diagnosis, and at times and provisional diagnosis. If at all he would have asked differential diagnosis, I was trying to steer my trail towards that particular diagnosis, which was quite obvious in the photograph. So that should not be done. This what I felt, that I was too um, I was too excited to just answer and quickly finish it off. This should not be the scenario. Although you have less time, and you're not able to revise properly at times, certain topics may be very strong, certain topics may be very weak, and stuff like that, and you have a tendency, to just tear it away from the thing which may land you up in trouble. And I felt that I did it very quickly
Oh,
in the case
okay.
of
Yeah, okay, sir. So we should take our time and then answer.
it's very important, sir, because there are many candidates who one of them straight away told granulomatous anterior uveitis, that the picture I showed. The examiner said, I never asked you the differential, I never asked you the provisional. And that ways we try to offend. So my take on this is that whatever you are seeing in the photograph, just describe it. If you are not able to see what examiner wants to show, he will guide you. And even at the start of the examination, the ones who help in the exam helpers, those females who actually take our phones and give us the badges, and explain the brief about the examination, they actually tell this repeatedly, that the examiners are not here to fail you. Remember that this is just a normal clinical discussion. Just imagine that you have come to your normal clinic day, and you are meeting new doctors from different countries, and there are these cases, and you just need to examine. You just need to see the photographs and have a normal discussion. Now, before that, now these statements would actually allay the fear which it is anticipated during the examination, sir. But what I feel is that it is easier said than done. And there are many things, if you start off with the management, you may forget color vision, contrast sensitivity, and you may and someone has taken visual acuity, has done everything, went on to discuss everything, but forgot the best corrected visual acuity and refraction. It happens. And at times it is forgivable also. But what you do not need to do is not to perform a blunder. If you do not know how to do it, that's okay. You can say, sir, I'm sorry, I cannot recall at this point. Fine, not a problem.
Okay.
So the day got over, and they offered us meal in the evening. And after that, I went back home. Now, see, there is 1 day gap between OSCE and clinical examination. What would be your mindset? Okay, the medicine part is over. Fine, all the stress gone. Now it is the clinical part. How to approach the clinical part. Now you will think that, okay, I can revise everything quickly, and I can just whatever it is written in the Prafulla Maharana, the book which you use, or the Dr. Chua's book which I consulted, it is not easy to revise each and everything. What I did, I took some I took some those the card like notes, okay, and I wrote down the examination techniques. For example, I wrote down examination techniques, anterior segment, how I have to go about. My hospital is quite busy, so I usually took those cards with me, flash cards basically. They're available on Amazon wherever you want to order. This is very helpful, very handy. So when I'm free, I cannot carry the textbook to the OT or somewhere else or the laser room. I just take out that. I put them in my apron. I take it out. I just run through the examination techniques. Okay, before starting the OPD, I run through the anterior segment, posterior segment, oculoplasty, and neuro-ophthalmology station examination protocol or examination scenario. Soon the patient comes to me, it comes to my mind, and I start examining. Also, I had practiced this. I would like to thank my DNB candidates, the postgraduate candidates over here in Gangaram Hospital, who were very helpful. Some of them also imitated as patients in the last days of examination. And also, when I was examining the patients, they took out the stopwatch and they could see in how much time I'm able to finish the examination. At times, you won't believe when I thought that my preparation is okay, and there was just 1 month left, and I started seeing my stopwatch time. It was 10 minutes. I said, "Oh my God, I have to finish at least two cases. How is this possible?" And this 10 minutes examination is taking. There is viva for the case also. Then I started to increase the speed, and this is how it comes to your spinal level. I would be discussing later why you have to bring the clinical examination skill to your spinal level. This is my take and my personal experience on this. This has to come at a spinal level. If you go there and you start your thought process on if you are doing right or wrong, examiner will make those facial expressions, exa- and it may scare you. They are there to see whether you're confident or not. They're not scaring you. They will be standing at a position where they will be have an eye to eye contact with you. That is very important. That is also one of the learning protocols, or one of the protocols they test whether this doctor is confident or not. Whether if I look into his eyes and he starts to fumble, that should not happen. So this, how to allay this fear, how to win over this fear, everyone, what I learned my way, how to allay this fear, was to bring the clinical examination skills to spinal level. When I examined on the clinical examination day, I was on fire, literally on neuro in the neuro ophthalmology station and the strabismus station. Believe me. And then when my examination got over, I was stress free. I knew that there are just 3 minutes left. And in 3 minutes, they cannot ask me all the classifications and everything. They will ask me the management, and that I can easily recall. So when you are eased out of the stress that you have performed your clinical examination well, you automatically start recalling everything. That is my take, sir. So I'll start with the clinical examination, day two. Quite frankly, the day the OSCE examination ended, I did not study. I slept off. The next day, I got up. I repeatedly revised the examination techniques. Some very important topics which I suspected may come, I examined. I revised those topics. I had made short notes of those topics. So let's start off. The station one was my oculoplasty, and this was a case of simple congenital ptosis. Examiner straight away introduced himself first to me. And on the OSCE day, also, both examiners introduced them to the candidates. The bell rang, and I started to perform the clinical exam. He said, "This is your case, doctor. First thing, you need to, the norm for United Kingdom examinations is that you need to use sterilium before touching the patient. So please make this also bring this also at your spinal level. Please bring this at your spinal level, that before touching the patient, you have to scrub, you have to rub your hands, you have to take, and if at all there is no sterilium, you can ask for sterilium quickly." So obviously there is a sterilium always available, and examiner, make sure this time you'll go and appear in the examination. You see, the examiner will actually observe you whether you're going and asking for sterilium, or whether you're using the sterilium to just you know apply your hands and then come up to the patients. These are also some, I think they carry marks. So he straight away asked me, This is your patient, doctor. Perform complete ptosis examination. I did. MRD1, MRD2, palpebral fissure height. Okay, then I asked the patient to look down in down gaze. Okay, and then I asked the patient to. I measured the levator function. Okay, and it was a child. Okay, but he was still cooperative, not a problem. And I wrote my values. I was speaking whatever I was doing. I was speaking. That is very important. That also comes with practice. I'm bringing the scale at the pupillary center exactly. Okay, this is the MRD1, this is the MRD2. He's listening. Examiner is listening. Then finally, after performing the examination, I was convinced that I performed it right. He didn't stop me anywhere in between. And the examiner asked, "How will you approach for the management?" Then again, I came up quickly with visual acuity, best corrected visual acuity, pupillary examinations, extraocular movement assessment, okay, and fundus refraction and prescription of glasses. It's very important to correct amblyopia first and plan a definitive surgery by 4 to 5 years by the time the tissues are mature enough to handle such surgical stress. So, examiner, what surgery would you perform? So, it's very clear to everyone. If it's a poor levator function, you go on with the sling surgery. If it's a better levator function, LPS function, you would go with levator resection. Now, very important question, and I think this question may have been asked several times. He said, "This is a case of unilateral ptosis. Would you like to check the other eye before look at the other eye before surgery?" I said yes. So, as you all know, that the child is trying to elevate his lid, okay, by the Herring's law. This actually reciprocates to the other side. So when this child is having ptosis on one eye, he's trying to lift up the eye more, so more power goes at this side and similar power goes to the other side as well. So there may be a contralateral lid retraction at times also. So what you do, you just elevate the lid on the affected side to ease the force with which the child is trying to lift up that lid, and you would see that the force is also concomitantly reduced as per Herring law on the opposite side, and you will see the lid falling down. This is very important for the position of the lid. So this time the bell rang. He had asked me to do the extensive examination of ptosis. So
So, Dr.
examination took
Dev, does this examination influence our conclusion or surgical planning?
So can you come again?
So, does this Herring law examination affect our conclusion or surgical planning?
Conclusion of surgical planning, sir, because if it's the to decide the level of the lid, sir, to decide the level of the lid, basically in unilateral cases.
Okay, sir. So, we should do the examination again with no. After elevating the contralateral eye, should we say that we should examine again, or we should look at something, or?
The examiner actually asked me that you elevate this lid. Why is it coming down? He asked me the reason, basically.
Okay, sir.
Okay. That's what's important for actually deciding the level of your lid that should be, because that is not the true level of that particular lid. Intraoperatively, you would be setting that lid to a higher level as compared to what it should be. In that case, you need to see this thing that when you elevate the lid and this lid falls down, so you need like for unilateral cases, you need to symmetrize the lid positions. And examiner was more concerned. He was more concerned asking me that why this lid is drooping when I elevate this affected side. So I had to explain this by the Herring's law. And this station, he couldn't ask me much questions. He asked me the management, the basic management. So see, the level of questions reduce, and the number of questions also reduce, because they are now examining your clinical skills. They know very well that you may be knowing the topic to the back of your hand, but still they are trying to now evaluate if you are able to examine or not. And usually there are 3 or 4 patients inside one room, and if you finish off with one patient, they'll quickly put another patient. And usually there are two examiners inside, And there is one examiner who is an observer examiner who's already cleared FRCS Glasgow and now has been offered to be an examiner. So he travels along with the main examiners to see how is the marking scheme done. So there are three people inside practically, and one examiner is a person who actually sees whether the right questions are being asked or not. So practically five people along with the patients. That is what is the scenario. So immediately the bell rang. I finished this in 4 minutes, 5 minutes probably. It did not 6 minutes. So the bell rang. I had 6 minutes more, and the other patient was the case of proptosis. Actually, the oculoplasty station was really stressful for me because both the cases had elaborative examination. Now, ptosis examination was is obviously elaborate. Thankfully, this was a proptosis examination, and this was a female of around 40 years. And he asked me to perform full proptosis examination in this case. Now, proptosis starts from inspection, worm's eye view, Knapsicker's view, palpation, and examiners taught me how will you measure the amount of proptosis after performing all the inspection and description. When you are doing your examination, you have to also speak up what you are doing. Now I'm doing the Nefziger's view. I can see, yeah, there is obvious protrusion of the right eye, and the right eye seems to be proptosed. Right eye seems to be displaced forwards like that, and this way you have to speak up whatever you are saying. Then by the time I came to palpation, I palpate. Why are you doing this? I'm palpating some thrill or something, and I'm also trying to look for any raised temperature or something. And then he said that how will you measure the amount of proptosis? By palpation, he stopped me because he knew that it is not possible, seemingly impossible to examine in such a amount of time. So he asked me about measurement of proptosis. I said Hertel's exophthalmometer. He said, "Have you done it?" I said, "Yes, I have done it." So he gave me a Hertel's and then asked me to do Hertel's on a patient and asked me to tell the reading on both sides. So I saw 26 on right eye, 20 on left eye. And so he asked me, "So it is right eye proptosis?" I said, "Yes, sir." So he asked me, "Tell me, how will you okay, I'll tell you that this is a case of thyroid ophthalmopathy. So tell me the management." So look at the questions. Now the questions are going very straightforward and they want very small answers to that. I told the management in details quickly and also told about the visa classification system. He stopped me then. He asked me which is the best classification to assess activity. So assess activity is the CAS score, clinical activity score, which is done at every visit. That is more accurate as compared to visa. Then I had time, luckily. So this was the third case which was put forth in front of me. Every case, again, shuffling between cases. When the first case got over, I again used sterilium to mop my hands and examine the second case. Then again, the third case, I again used sterilium and for the before examining the third case. So examiner just clearly asked me what surgery he may have undergone. I said evisceration. He said why evisceration and not enucleation? I said I can identify the sclera and there is a prosthesis inside. I asked the patient if he could move his eyes left and right and extraocular movements could be demonstrated. So I said this is a case of evisceration. Examiners then started asking me the indications of evisceration and enucleation. I answered. Examiner then asked me if this is a case of evisceration post-traumatic injury, like an kind of a open globe repair or something, which was not amenable to repair, and that time the eye underwent evisceration. So would you look for something in the other eye? I said yes, sir. It just spontaneously came to my mind. I said sympathetic ophthalmia, and the bell rang. The case was over. Then I came to the second station, that was the anterior segment. It was a case of healed keratitis. And I started to describe the anterior segment findings while I moved from the lid margins. Remember, lid margins come in the anterior segment. So you need to comment upon the lashes, the placement of lashes, the meibomian openings, and if there is any component of meibomian gland dysfunction, if you can decipher, if there is any tracheitic lash and all, this comes. Puncta is well opposed to the globe. These are the words which you need to speak while examining. Okay, so I started to describe the anterior segment findings, and while I moved from the lid margins to the puncta to conjunctiva to the cornea, and it was a leukomatous corneal opacity, I described the dimensions in details and the level. The examiner then said that, let me give you a hint. This patient suffered trauma while working in farms with the vegetative matter. So he wanted to ask me, what do you think can be a likely etiology to this? I said, as you said, that this is a patient working in the farms with vegetative matter. It may likely be a fungal keratitis, healed fungal keratitis. So he said, how will you manage fungal keratitis? I started with from corneal scraping. He asked in details about scraping procedure. I told him about the same. Culture media, method of plating. Method of plating culture media was asked in extensive details. He asked in extensive details about the corneal scraping procedure, and I told him everything. So examiner said, what treatment will you start the patient? I told him about initially empirical therapy, broad spectrum antibiotics and antifungal after taking the samples for culture. Then I went on to speak regarding the treatment. He explored more, like treatment failure, resistance to the antimicrobials and rescraping, which I told what is how is to be done. You all know as it is. So he looked convinced, and then examiner asked me, how will you rehabilitate this patient? I said, if there is scarring, I will assess the depth, and just quickly said full thickness penetrating keratoplasty, and the bell rang. Second case came up immediately. Now this was the case which actually was problematic for many doctors, because um, after the exam finished, my colleagues, I had a discussion with them that which this station, which case was really problematic. So there is the second case of that small that girl who was there, and and there was iridodonesis. So I examined he said, examiner straight away again, before shuffling to the other case, I used sterilium. Then I examined the patient, and he said, examine the patient, tell your findings. I examined in details and couldn't find anything. The time was ticking. I thought I was losing on something. I was just clueless. There is a constricted pupil, okay, and the iris looks normal, cornea, anterior segment, everything looks normal. Lid margin is normal, meibomian gland is normal. There's no dysfunction, okay. Puncta is well opposed to the globe. I come on to the conjunctiva, it's normal. Limbus is normal. Anterior segment, no cells flare. Everything is okay. Then suddenly the patient moved his eye, and I saw iridodonesis. And then I asked the patient, the pupils were constricted. I asked the patient to move his eyes in extremes of gaze, and by chance I saw the edge of the lens. Examiner that time asked me immediately, what is your provisional diagnosis? I said ectopia lentis, bilateral. When I examined the other eye, it had the similar finding, iridodonesis, although I could not visualize the lens edge. Now, here I was, as Sir asked previously, what was the mistake? Here I was wrong. This is not the way actually one should go. I was lucky though, but still, I saw one lens, I saw iridodonesis in the other eye, and I didn't see the edge of the lens, quite frankly. But I saw the edge of the lens in the right eye, not in the left eye. So I thought it may be a case of bilateral ectopia lentis. But fine. He went on with his questions. He asked me, "How did you diagnose ectopia lentis?" I said, "I saw the edge of the lens." And he said, "Had you not seen the edge, lens edge, what would you do now?" I said, "I would dilate the patient. I would dilate his both eyes and see and perform refraction and fundus examination as well." Examiner was convinced with this and asked the differential diagnosis. I told all about Marfan's, Ehlers-Danlos, Gilmar-Chesaning, and all the syndromes which I could remember. Ectopia lentis at pupillae and post-traumatic subluxation of the lens. And because it was easy, this topic was easy because I just revised a moments before, and the station really went well. The third station was the neuro-ophthalmology ocular motility, the pupillary reaction assessment. Ladies and gentlemen, please be very careful with this station. Okay? They checked each and every move of mine. I moved into the room. They said, "Hello, doctor." They introduced themselves, and here is your patient. The bell rang. I immediately took sterilium, smeared my hands with the sterilium, and now started examining the case. He said, "Go ahead with pupillary reactions." I immediately told, "Can you switch off the lights, please?" First, I said, "Switch off the lights." Then I said, "Switch on the lights first." I went near the patient. I asked the patient to look at the 660 target. There was a Snellen hand hanging in front. And I asked the patient to look at the letter A, which was the 660 target. And I saw that there was no anisocoria in light. I said, "Sir, there is no anisocoria in light. I would like to switch off the lights now." And then I again checked. There was people used one torch, or I used two torches basically. The second torch is actually held uh, by my own hand, was held by my own hand. Some actually asked the examiner to stand by sides and hold it beneath. The light should fall at the root of the nose. Okay, that is the area where you need to illuminate both eyes. And then with one of your torch in your hand, you need to check for pupillary reactions. So I examined, I did that. I used my the left hand to glow the torch at the root of the nose to diffusely illuminate both eyes, and with my dominant hand I checked the pupillary reactions. Okay, and this was the way. And before that I also told there is no anisocoria in dark, and then I went on with pupillary reactions. So in pupillary reactions, after performing, be very careful with this. You have to ask them to close the lights. You have to ask them when to. You should know when to ask them to switch on the light, when to ask them to switch off the lights. They observe this. This station, this pupillary reaction examination carries marks. If you're not able to do this, they know you're gone because
Dr.
you.
Suvir, can I ask just one question? Sorry to
Yeah,
interrupt you.
yeah.
So for first you just go into the OPD and just tell them to dim the lights. So when you dim the lights, do you shine any light source or something
Exactly.
to
Yeah,
check?
yeah, yeah, yeah. That's what I was telling previously. That when you dim the lights, first you need to see in the normal light. Ask the patient to look at a 660 target. Examiner also asked me, "Why are you asking to him to look there?" I said, "I want to relax his accommodation."
Okay,
Then after that, the lights were closed. The lights were closed. Obviously, there would be like they switched off all the lights. So you need another light source to diffusely illuminate both eyes. Okay, so that's the second torch which I had. Okay, so second torch, actually I held it in my non-dominant hand, just near the chest of the patient, and pointing the direction of the light to the bridge of the nose, the root of the nose, sorry. And root of the nose, it diffusely illuminates both eyes. And from my dominant hand I started checking the pupillary reactions. Okay, this video is there. I just talked about the YouTube video of Dr. Ghada. It is very long, very extensive, but worth it, believe me.
okay, okay, sir.
Just see that video. You will never fumble with pupillary reactions.
Okay, thank you.
Also, luckily I did not have this confrontation perimetry, because it took a lot of time, because the first day candidates after the exam was over told me that there was a patient where they asked to perform confrontation perimetry, and that was a case of pituitary adenoma and bilateral bitemporal hemianopia. So Dr. Ghada's channel also has the examination video of the confrontation perimetry. Very clearly, I must tell you, the examiners look at what position you are placing the target. It is exactly at center between you and the patient, at an arm's distance. They see each and every move of yours. So be very careful. At times, what happens, you're bringing the target from periphery to the center, mapping out the visual field, and checking. Sometimes the wrong eye is covered. Okay, the right eye is covered. Even at times, you're bringing the target. You're bringing it sometimes closer to the patient. You're bringing it sometimes closer to you yourself, and not the exact center. You be very careful about that. So this thing is succinctly described in Dr. Gada's YouTube video channel.
Okay, sir. Thank you.
Yeah. So after performing examination, I said left eye RAPD. Okay, so the examiner asked me what are the DDs of RAPD. I gave them the DDs, that the optic neuritis, that may be demyelinating optic neuritis, traumatic optic neuritis, neuropathy, advanced glaucoma. Okay. So examiner said, would you like to check again? Please read these words. Never hesitate to check again. See, pupillary reactions, when I read the candidate experiences, they said, oh, this happened, oh, that happened. I was not able to switch off the lights. It took time. The patient was not cooperative and stuff like that. So, all these things are written about pupillary reactions. So, it gives a kind of a image to your mind that, okay, this station is really problematic. That's what I previously discussed at the start of this session, that mindset is everything. So if you're too you know about the station that this is going to fumble, you'll go with the mindset that you'll do something which may actually lead you to fumbling in the station. So I examined the pupils in haste. There was an RAPD, no problem. But still, examiners, when they asked me about the why RAPD happens and everything, and they knew that I have talked about an isochoria, so they knew that I know efferent afferent pathways and everything. So they still wanted me to check it again. So never hesitate. I checked it again. I said, sorry, sir, it is actually right RAPD. So they were okay with it. Then they asked me, how would you proceed? Tell me the approach. Briefly, I told about fundus examination to look for indespal or something, red free fundus examination, visual field, the fundus examination, optic disc. You can also look for cupping for advanced glaucoma, asymmetrical advanced glaucoma. Then you have visual field. You can do a visual field. You can do an OCT, RNFL, and also the visual evoked potential. And by this time, I had completed most of the things, so the bell rang, and this thing was over. Then the second case was exotropia with V pattern and bilateral inferior oblique overaction. Now again, see this. They were more concerned about my examination techniques. They asked me to perform cover test, uncover test, alternate cover test, and asked me to demonstrate the inferior oblique overaction. The examination took all the time, but I was convinced that it all went right. They didn't stop me anywhere. Then they asked what would be the management. See, I was stress free. My examination is over. My examination part is over. I'm done. So they asked me surgery. I said surgery for horizontal muscles with vertical transposition, as you all know, in cases of low grades of IOA, or if inferior oblique weakening procedure in cases of higher grades. Examiner looked convinced, and it took a lot of time in this examination. They checked everything, and the bell rang actually. The station
Sir,
was over.
can I ask one question?
Yeah.
So how do you demonstrate inferior optic action? It's just like the normal our H pattern ocular motility test only, no? Same
Yeah,
thing.
ocular motility. Elevation in adduction.
Yes, sir, okay.
Very pretty simple. There are two methods to grade that. The one method is that the horizontal line is drawn at the bridge of the nose and the direction of the eye is measured. There is an angle between both. So that angle is 0, 10, 20, 30 degrees, the height of the eye, and the severity goes more. That is the grade 1, 2, 3, 4, like that. So that's the Jampolsky system of grading, which you can see. That also gives the deficit in -1, -2, -3, -4, or +1, +2 over action or under action. That Jampolsky paper is very important. Do read that. Then the final station came in. That was the posterior segment. And I also must tell you one thing, that I was given 5 minutes of a break, to 3 or 4 minutes of a break, in case of during the OSCE examination. But this clinical examination, soon I was out within half a minute, 30 seconds. I was in. So be very sure that you have, gone to the washroom. You will not be allowed to go in between. Be very sure you've had water. Okay, keep yourself hydrated, because you will not be allowed to leave the examination station or the room in any case. Even if you have to go, you'll lose time. There is no turning back. So uh, the posterior segment, I got right eye CRVO only, and Examiner asked me to perform a slit lamp biomicroscopy examination. They saw all my actions. How did I choose the lens? I took 90D. What was the distance from the eye? Slit lamp. Where did I ask the patient to look? And how did I place the lens in front of the eye? How did I move the slit lamp biomicroscope um, little behind and posteriorly to get the fundus to focus? I performed in a standard manner and described all the findings. So all the questions were mostly similar to the OSCE part, which I has just previously discussed. But just one question, that what if anti-VEGF does not work? So I said that I'll try by switching to another anti-VEGF after I'm done with working with one anti-VEGF. And he said that if that doesn't work, then as per NICE guidelines, I use this word NICE guidelines. So I'll give intravitreal sustained release steroids, that is the Ozurdex. Examiner looked convinced with this. So this station, then the bell rang, and this was the station. The second examiner came up, and this was a young girl, and little uncooperative with the examination. The exam, and I used sterilium again. Remember sterilium. Before touching the patient, you use sterilium. They will observe you while you are using it. Are you using it or not? These carry marks actually. So examiner straight away said perform indirect ophthalmoscopy. Do the indirect ophthalmoscopic examination. So first, I asked the examiner, so do you want me to that I should make the patient supine and then examine? He said, no need. You examine just straight away. Patient is sitting. All right. So it's a good thing to ask to dim the room lights and everything. I started off with the lower intensity beam so that the patient gets accustomed to the examination and slowly increase the intensity. Although she was trying to close the eyes every time. And I started to do the standard way of indirect ophthalmoscopic examination. Foveal reflex looked dull in the left eye, rest all was fine. So examiner asked me, like I just said, everything looks fine, only the foveal reflex looks dull in the left eye. Examiner said, are you sure? I said, I can see media haze. I need to evaluate the patient on slit lamp. Now see this. I said, I can see media haze. I need to evaluate the patient on slit lamp. Examiner said, no need. No need of slit lamp. There is no need of slit lamp. Ask the patient to look down. See, he helped me. Ask the patient to look down. I politely asked the patient. She looked down and I could see snowballs. Finally, I immediately said, intermediate uveitis. He said, what all investigations, management, and he asked about the Kaplan's four-step approach. I answered them all. So this way, my stations got over, and the bell rang. And all in all, to summarize, for all the candidates and who are about to appear for the examination, first thing, stop. Like for example, if you just have 1 month left, there are various ways. See, I am my work is quite busy. I have a busy schedule, so I knew I needed around 6 months or so to prepare well. So you need to plan your time, organize yourself very well. Okay, it is not that you need to read for 6 hours or something per day. Many experiences actually told that you need to read for 6 hours per day. 6 hours with a clinical responsibility, clinical duties. I personally feel that's impossible. But yet, people may be lucky that ways, that they may spare time or may get time to study well. But in my purview, it is around 2 hours of study per day will suffice, but 2 hours of selected study. Please understand, as I said, Kansky's every word, every line is important. That does not mean that you need to gulp down Kansky in one go and every time gulp it down. It is seemingly impossible to remember each and every word of Kansky written. It's a 1200-page book. Come on. So, what's more important is that the past candidate experiences. What me and my crew did was to actually uh, scroll down. I told them, let's do one thing. First, we take a 15-day or a 20-day, maybe. There are many experiences. We got them printed out from a local shop. And I said that let's sit down and just start studying Just read it like a storybook, no problem, and just write key points or key questions in a small diary. Okay, we divided amongst ourselves, and we were done. Now we had the jargon, we had the important topics, we had the important questions pertinent to those topics, and we were good to go. After that, we started reading Kansky line by line, page by page, but we were more focused on the topics which we had shortlisted from that past candidate experiences. We were very seriously studying those topics, every word, every line, everything. And we also even pasted some bookmarks over there, those small sticky notes over there, just to recognize that these are the important topics out of this Kansky. Okay. Then also, like for example, CRVO, diabetic retinopathy, and all, we needed to search for some articles, the landmark studies. Okay, this was a fungal keratitis. Had it been a herpetic keratitis, I have seen past candidate experiences where the examiners have asked about heads trial, herpetic eye disease study. That's very important. Then, as we finished the course, we were happy that we finished the course around 1.5 months before the actual exam date. Okay, there is another discrepancy, like candidates I've seen waste too much of time in booking the examination. Then there is some visa problem or something of that sort. That is a problem which is quite well understood, but you cannot do much about it. They have a window, the UK people have a window that you can apply if probably you cannot get the visa to the particular country where you intend to take the examination. Not a problem, we will just deduct the administration fee and refund all your money. No money is kept. There were many candidates whom I know, and we had discussions on WhatsApp and Zoom as well. And who those who couldn't make it to New Delhi, their money was refunded instantly. So that's not a problem. And do not waste too much time in gossiping about, how would be the exam, what is the war situation, is there some bombing going on or something of that sort. That is not your cup of cake. Your focus should be on the examination. You've applied. Okay, I admit it that this is very difficult actually. It's easier said than done, because I had applied for the examination. Now they said, thank you for your response. Your response has been noted. We will revert back to you. Now that revert, those 7 days or 10 days, 14 days, it's actually troublesome. You don't know whether you're appearing for the exam or not. You're not sure you have been selected or not. Are you in the waiting list? Are you in the there is one more list actually, waiting list. Candidates must be knowing, and uh, waiting list candidates have stand a good chance to get through the examination. There is one more list, okay, that is little tricky. So if you are in the,
Standby list.
yeah, exactly, sir. Thank you so much for reminding me. That's a standby list. So if you are in that standby list, you are here or there, but that happens in a matter of few days or seconds. What happens if you are in a standby list? You're preparing, okay, and you're not sure whether you're giving the exam or not. Believe me, when this thought comes into your mind, your efforts go down, substantially go down. The vigor and passion which you used while preparing for this examination, that is reduced to just 20%. Oh, you open up the book and say, oh, I'm tired today, let's not think, I don't know whether I'll be appearing for this examination or not. What's the point in kicking yourself so much? No problem. Then comes the bomb. Suddenly, 3 days before the examination, you get an email from Glasgow, and they say, you've been shortlisted from standby list, vacancy available. Kindly pay up immediately to process 1 week before the examination. Now what? Now you would start thinking retrospectively, oh, I wish I could have studied. Oh, I wasted my time. What happened? There's just 1 week left. In this 1 week, what I will be able to do? Clinical examination, patient scenario, whatever, OSCE, paraphernalia which you need to carry, visa, tickets, if you're the same country, tickets, hotel booking. If you're on a standby list, let it go. This is my take on it. Standby, you get lucky or not. And if at all you're bold enough to take the standby list, I would say keep studying. Think as if you got through the examination, you got a seat. If you don't get it, don't get disheartened. But you need to have that mental strength. Then I got through the examination. I got that congratulations, you've been shortlisted listed for the examination. We would be sending you all the PDFs and all documents. Kindly fill up the form, scan it, and send it back to us. Make the payment, and all that is the usual stuff which they send after you are booked for the examination. Finally, the payment was made. We were booked for the examination, and they wrote that you're finally booked, and this is your candidate number. That point of time, we all got very serious. That was the time when we all started studying seriously. We divided time, we managed time. What was the reason for our success was time management. Be very clear about it. Time management. We did not waste. There were many groups, all the gossip going on. What will be the examination? Oh, this is not the right answer. No, you're not concerned about that. You are as a group, as a niche, a small niche. You guys have studied together. You have a great coordination. Start studying right away. So what we did in the final days, 1 month before the examination, we picked up that the jargon of that past candidate experiences. We started studying in extensive details, repeated revisions per day, taking down small notes. I bought those flashcards as I told you. Flashcards were not just for anterior segment or all the four station examination techniques. Flashcards were also of differential diagnosis. I had made bundles of 3 or 4 flashcards. One flashcards contained examinations, one flashcards contained differential diagnosis, one flashcards contained summary of all trials, endophthalmitis, vitrectomy, heads, EMGT, and AGIS, and all the landmark studies. Okay, diabetic retinopathy, all the studies of that. So these flashcards were a boon to me. Please believe me. They were so handy. They were in my apron. I was eating food. I thought that I should revise this. Okay, I was thinking, oh, I just forgot that uveitis trial, that must trial. Okay, just open the flashcard immediately. So run through the summary. Done. Job is done. You don't need to elaborate everything. You don't need to tell the Kansky to the examiner. You just need to tell the salient features and points which you have understood. And those flashcards, fill them up cleverly using your brains so that you actually write relevant points which can be revised. You don't need to write an essay or a story. You need to write relevant points. These relevant points are such constructed after repeated revisions, which will actually get you through the main chunk which you need to speak in front of the examiner. Before the examination, we were left with 15 days. We had revised and everything. And also, 1 month before the examination, we all friends started to practice clinical skills. A time came when there was scarcity of patients. All of them came to my hospital, Gangaram Hospital, New Delhi. My bosses, Dr. S.N. Jha, Dr. Amit Khosla, who are senior consultants over here as vitreoretinal specialists, they were very friendly and very helpful for this. I asked them, sir, I can, use the OPD room for clinical examinations and setting the clinical scenario. I did that. I took all my friends. I said, let's replicate this scenario. Okay, one of you stand outside. You will be the exam helper. Okay, you will be standing inside as well. Two of us will be examiners, one of us will be the candidates. Timer starts, bell will ring, everything. We replicated the real scenario. And that time we got stressed out. I said that, hey, we are losing time. It's 12 minutes for one case, 15 minutes for another case. How is it possible? Then again, we started running through. We imitated as if we are suffering from ptosis, or we are suffering from proptosis, or some anything, any clinical scenario. Then after that, I think by repeated clinical examinations, this was our fear actually. I'll be very frank with you all. This was our fear. What if he's observing? I said, you are the examiners now, so you be the examiners and you stand in front of me, just face me. If I'm trying to hide my face, come over me, look into my eyes, try to scare me, scare the hell out of me. I don't care, but I need to get away and move over this fear. Otherwise, I know what will happen. Slowly and gradually, 15 days continuously we did this. It actually came to our spinal level. And when we went to give the examination, we thought it's just a routine. Just one point which was scary, that was emergency medicine. That is acceptable. And I felt that the external examiner, the examiner for the emergency medicine, also was very lenient. He knew that, okay, you're ophthalmologist, you may make mistakes and they are forgivable. So now come to the judgment day. That is the 24th. My session was afternoon session, and very important is that if you are coming from some other city or something, you need to book the center your hotel, your accommodation very near to the center. At times what happens is that you may not find a public conveyance, or you may not find a conveyance to your exam center. So what I would prefer is that if there is examination, that in New Delhi, for example, it was Shangri-La Hotel. So there are many adjoining places in New Delhi, Karol Bagh, Patel Nagar, where you can easily hire one room for yourself, book one room accommodation for yourself. There is a direct metro line from Patel Nagar to. So you need to plan your itinerary. You need to plan your itinerary for the examination. This is also a part. I was lucky that I reside, born, and brought up in New Delhi, so I had no problems. So I knew that I had to reach the center 2 hours before. Not a problem. You just sit in the lounge. The OSCE part will be conducted in a hotel. I suppose Bangalore has the Four Seasons Hotel. Uh, that will be your center probably for the OSCE. OSCE is usually a hotel. So just go down to the lounge. Make yourself comfortable. What's more important for you is to reach there on time rather than running after and adding to your stress. Reach there on time. I reached 2 hours before. I sat in the lounge, sipped some water. After that, I went and checked in to that FRCS examination rooms. Okay, there was a small dedicated hall over there. The access was denied to everyone. They asked me for the that my identity card, and then only let me in. I sat down and made myself comfortable. There were some snacks offered. There were some cold drinks and all. They were offered. I had some snacks and just eased myself to the examination. When you go to the examination, just remember one thing in your mind: whatever you see, you don't need to miss. You may not be knowing the total. They are not concerned whether you know macular hole or not, whether you know fungal keratitis or not. They are just not concerned. They are concerned that if you are seeing a patient, are you telling all the findings, or are you missing any findings or not? You should be able to look for all the findings. You should not miss a finding. That will land you up in trouble. If you're not able to tell Roper Hall classification, if you're not able to recall the glass classification for macular hole, not a problem. But if you're not able to see macular hole, that is a problem. Sorry. And the day got over with the OSCE examination. We were all through. As I told, I did not study that day because I needed relaxation. Okay, there's a lot of stress. It's easier said than done. I always say there's a lot of stress during the OSCE examination. I preferred to relax so that I can make up for the clinical examination. Everything is similar. I had my notes prepared. I had those flashcards. There was nothing new to do. So why to unnecessarily stress yourself out? The next day, I just revised. I kept calm. I talked to my mother and my brother. They calmed me down. I talked to my friends also, and also said, no need to see social media or any kind of WhatsApp or any video. Just calm yourself down. Okay, go for a digital rehabilitation at least for one day. And after that, on the clinical day, as I told that the and one thing more I would like to mention. I was lucky enough that again I reached the clinical center. My session was afternoon. I reached the clinical center at 12 o'clock, and my session had to start at 2 o'clock. So now I could see some candidates who came in and sat down besides me. At that point of time, I thought that okay, what all cases can come? Ptosis can come, proptosis can come, okay, and extraocular motility, pupillary light reflex examination, confrontation, perimetry. I had made the list. This was there in the flashcard, okay, and then after that, I thought that I should examine something. I should I should try to approach these people. I asked my colleagues who were there besides me. I didn't know them. Someone was from Iran, someone was from some other country, and two of them were from Mumbai. And I asked, "Hey, listen, I just wanted to say that we are just about to start the examination, just 2 hours. I just wanted to quickly recapitulate the clinical skills. If you are with me, you won't believe. They all stood up. They said, "That's not a problem. Examination has not started. We can talk. Not a problem." We sipped the cup of tea. And again, I said that we will imitate as patients. You perform examinations and vice versa again. So just before starting my clinical, I had a quick recapitulation of my exam, what I had to appear, what I had to perform just moments before the examination, all the techniques. That eased a lot of pressure from my mind, believe me. And per se, for clinical examination, I had no stress. I performed, and rest is all up to God. Uh, I believe in God, yes, and I believe that what best I can do, what best I can make out of my time, I can do. So, all in all, it was a great experience, and I hope that this video has helped you all a little bit. And I would be sharing my contact details if anyone requires any personal help from me uh, pertinent to this examination. My email ID and my mobile number. If you feel free to interact with me, and I wish you all the best. And Bangaluru's examination is, I think, is on. I don't know if what is the situation as of now pertinent to the war situation which is going on. So I wish you all the best, and please believe me, this exam is easy to pass. It's only your mind, past candidate experiences, something else which is distracting, and trying to tell that this exam is very difficult. If you approach this examination, I believe you all will succeed, just with a pinch of positivity, and ignore all the negativity around you. Do not just listen to anyone. Have faith in your skills and you'll perform great. Don't think about the results, whether I'll pass or fail. Go with this mindset that I have to do my best. Okay, and go with this mindset as well that he's my colleague, he's my senior colleague who's come from a different country, maybe UK, maybe Iran or somewhere, and I have to discuss this case with him. So thank you so much, and I hope you all uh, like my presentation. Uh, Whatever I could gather, whatever I could remember, I have shared everything in this. Thank you so much. Over to you, Dr. Kaushik, sir.
Thank you, Doctor, for this detailed sharing of your experience, which will help us a lot.
I hope it was informative for all of you. And I think Sir has actually recorded this session. And Sir, I just saw the. So, hello, can you
Thank
please
you very
come
much
up
for
again? Someone was asking something actually. So, okay, not a problem. Thank you so much for interacting. And this was my session. I hope it has been recorded. I can't see Kaushik sir right now, but I saw the message in the chat box that probably this session has been recorded. Sir has written in that chat box. So,
Yeah,
anything
thank you,
else?
Dr. Suvir Dev.
Yeah, anything else? If someone wants to ask me, or I'll end the meeting.
Yeah, there are actually many things which we can ask. I don't know where to start. I'm just worried we don't make any fatal mistakes in examination. I'm really worried.
Sir, I would like to say one thing that believe me, this there is no such thing as fatal mistake. We have to change our mindset. I know I'm talking something which is very difficult in practicality, but if you adopt this, it would do wonders. If you go with a positive mindset, sir. We examine every day. You have to bring your clinical examination skills at spinal level. This was my take on this examination, sir. This was my second attempt. I appeared for the first attempt in Bengaluru, and there I fumbled. I actually analyzed my skills, what went wrong. So I passed all the OSCE stations, and I fumbled in neuro-ophthalmology, pupillary reaction examination, and I fumbled in the retina station, one of the patients. So two patients of two stations. Because of that, I couldn't pass. Rest I all passed in the band.
Okay. Okay. Okay, sir.
So just think positive, sir. You can do it. Everybody can do it. Go with a positive mind and please practice clinical skills on your patients, on your colleagues, and repeatedly, as fast as you can, as much as you can. I wrote
Okay,
it
sir.
previously in my presentation as fast, as much as you can, and you'll get through. And also, if you perform badly in OSCE, not a problem. They will not fail you. They will are more concerned about clinical examination. If you perform averagely in your OSCE and you perform well in your clinicals, you are passed.
Okay, sir.
And if you perform badly in clinical stations and you have rocked the examination of in the OSCE part, at that point, sir, this is the very higher chance, very likely chance that the person will fail. They are more concerned about clinical. Okay, sir.
Okay, sir. Thank you.
Thank you so much. Thank you
Hello,
so much,
sir.
all of
Thank
you.
you for
Just
your
one
time,
more
sir. It
question,
was
sir.
very helpful.
Yeah, please, someone,
Yeah. Hi,
Doc,
sir.
Dr.
Yeah.
Meenu. Yeah,
Thank you very much, sir, for your class. It was very helpful.
yeah,
Sir, I just wanted to ask like this. I'm appearing in the Bangalore session in 1 week's time.
yeah.
So just a few days left.
Yeah.
So what would you suggest, sir? Like now, like in 1 week's time, what would be the best thing to do now?
The
I've
best
been
thing,
preparing. Yeah.
yeah. Have you been preparing with a group or individually?
With the group.
Great. So, when are you planning to reach Bangalore?
Like 2 days before the exam.
2 days before the examination. So, take my words, okay?
Yes.
Just make a small handout of clinical examination techniques of all the stations, okay?
Yes,
Uh,
sir.
you may be having that Moonlight Academy of Summary of Emergency Medicine if you have, or
Yes,
Oxford
sir.
Emergency Medicine. Just take
Yes,
that
sir.
book along with you, okay? And when you reach there, just start off with one day. You would just discuss the OSCE important topics of both past candidate experiences, okay?
Okay.
The second day, you would be doing clinical exam. The first day, you would be doing clinical examination. I'm sorry. You would be doing
Okay.
clinical examination for commonly asked topics. Okay. Ptosis
Okay. Okay.
examination, ocular motility examination, strabismus examination,
Mm-hmm.
neuro-ophthalmology, pupillary light reflex examination,
Mm-hmm.
confrontation perimetry. These are the
Yes.
things which you have to perform in front of the examination. Slit lamp
Yes, sir.
biomicroscopy, indirect ophthalmoscopy, you won't be able to do. Okay, but you must
Mm-hmm.
have done, I believe, and that is the only these examinations: IDO examination, indirect ophthalmoscopy, biome, binocular indirect ophthalmomicro, that ophthalmic, the slit lamp biomicroscopy, and these are not problematic. Everybody can do. Okay. I would
Yes.
also like to inform all of you that please take your own 20D lenses and 90D lenses. I took myself. I was comfortable with them because at my center in Delhi as well as Bangalore, there were a lot of scratches, and in the 90D, it was very difficult to visualize with that. And also take your own occluder. Okay, you need to. There is a. I bought the occluder from Amazon. It was available, so you can take that occluder along with you. You would require it for cover uncover tests. Okay,
Mm-hmm.
you need
Yes.
to take your own torch. Okay, you need to take your own targets, that colored targets, for the confrontation perimetry, mapping out the blind field, blind spot, and all. Okay.
Hmm.
And for that red desaturation test, you all know, for the
Yes.
pituitary adenoma. So you need to take that those pins which have colored tops, that are also available. So you can just try to cut the pointed part of that and just hold
Hmm.
that pin which has a colored
Hmm.
top. It may be red or something. You
Hmm.
usually require a red pin, okay, for
Okay.
confrontation. These
Okay.
paraphernalia, the scale also, the scale you require. Okay, I was not comfortable with the scale which is transparent. I don't know why.
Hmm. Hmm.
And
Hmm.
I must tell you, you also see there is a scale which you get in that surgical drape surgeons wear. Okay, that you get a marker and a scale, na? So
Hmm.
that
Yeah.
scale is white colored.
Hmm.
That
Hmm.
paper type scale is
Yeah.
white.
Yeah.
I
Yeah.
felt that the contrast was better, and I was easily able to decipher there was no reflex from the torchlight, and I was quickly able to do the MRD1, MRD2 at the ptosis.
Hmm.
This was my personal observation. Although the transparent ruler may also help. Transparent ruler
Okay.
you may use, but there is a lot of light reflex. You need to adjust every time and stuff. So these things,
Hmm.
like little tweaks from the usual, I thought
Hmm.
I have experienced some difference. So I felt that you may also feel some difference with that. And please carry your paraphernalia. This is my suggestion to all of you. Your own torches, okay, and your own examination, the above whatever I told right now, like the pins, okay, the scales, 90D, 20D, not a problem. Just carry them,
Hmm. Okay. Yes,
okay.
sir.
So
Okay. Thank you so
anything
much.
else? Anything else, all of you? I think we're done for the day. Everything is recorded. So thank you so much for connecting, and I wish you all the best for the upcoming examination. I'll always stay connected with all of you. Thank you. I'm ending the meeting right now. Thank you.